All right. No, thank you so much. Yeah. So we have our team of registrars from the unit. So we have actually had about 3 or 4 cases, if I'm not mistaken, of Gaucher's disease that we've been able to diagnose with some collaborations that Dr. Chira has fostered. So this is one condition that I think it's pretty fairly new for our setting in terms of diagnosis and also in terms of management. We've been able to have one patient that has actually received some help in terms of therapy, but we thought this was a presentation that would love to hear your views as well, and also ways in which you can better improve our management of patients that we are investigating and finding, and then also what further collaborations we can probably foster, or direction that we can probably go towards to sort of raise awareness, of course, for the presence of Gaucher's in our setting, but also how else can we properly diagnose, fully diagnose, and also give them appropriate management for better outcomes, or as better outcomes as we can given our settings. So I think with that said, I'll hand over to the team. So Dr. Namwaka will be presenting, but she has with her the other registrars, Dr. Mwanza, Dr. Mkoka, Dr. Chavu, and Dr. Msole as well to give us support as well. So over to you, Namwaka. Please go ahead.
Thank you so much, Dr. Taylor. Good afternoon, everyone. I'm Dr. Namwaka, and I will take you through our case that we're presenting this afternoon. Going right through to the presentation. We are presenting, let me just share. Okay, so this is our outline. We're going to do the history, the investigations, and the management for our patient. So on the demographics, our patient was a WT male who was 6 years old. He came from the Copperbelt province in Kitwe. He's a first grader, and he's a Christian by religion. Our patient presented with an abdominal mass and abdominal distension for 3 years. So this is a patient who had a history of the abdominal distension with a mass, which was noted to be progressively increasing in size. This mass was associated with abdominal pain with B symptoms. He could have some occasional diarrhea and vomiting. However, there was no hematuria, no hematemesis or epistaxis, which was noted. The review of systems was unremarkable. The past medical history, he had a history of admission at the local hospital before he presented to our facility. At that local facility, he had received some blood transfusions on 2 occasions. He had no comorbidities, and he was RVD and ARA, and no history of any TB contact. He was on hematinics by the time he was presenting to UTH. He was born at term via spontaneous vaginal delivery. There were no complications at birth. He attained all the milestones for his age, and he had received all his vaccinations. He was firstborn in the family of 2, no family history of similar presentation, and there's no history of hypertension, asthma, sickle cell, or epilepsy. On his social history, he lives with his grandparents and mom in the Copperbelt. His parents are divorced, and but they live in the same town. The guardians are not in formal employment, that's grandma and the mom, and they are not on any national insurance scheme. However, in his situation, he was put on the national insurance scheme by a well-wisher. So this boy he is a very intelligent boy, and he performs well at school, and he has very good social skills. When we examined him, he was awake and he was not in respiratory distress with the GCS of 1515. He was moderately pale and he had no jaundice. He had axillary and mandibular lymphadenopathy. He was wasted and he had a weight of 17.6 kg, a height of 103, which put his BMI at 15.37, making him underweight. His vitals were within normal range with a heart rate of 109 he had a respiratory rate of 22 and saturations were at 99% on room air. His temperature was at 36 and he had a blood pressure of 102/61. The systemic examination, he had the respiratory system, had stable respiration with vesicular breath sounds and equal air entry bilateral. His cardiovascular exam, he had warm peripheries with good volume pulses with a capillary refill time of less than 3 seconds. He had no gallop and he had the abdominal exam, he had noted obvious abdominal distension, which was moving with respiration. It was soft. However, he had a hepatomegaly, which was measuring 12 centimeters below the costal margins, and the surfaces were smooth. The spleen was also enlarged with a measurement of 24 centimeters, making it a grade 5 with smooth edges. He had a positive shifting downwards. The musculoskeletal system was unremarkable. So to summarize our case, this was WT, a male 6 years old, who was RVDNR, who presented with a 3-year progressive abdominal distension, which was associated with these symptoms. However, he didn't have any bleeding tendencies, and he had axillary and mandibular lymphadenopathy with a massive hepatosplenomegaly with decompensated anemia. This was a full blood count that was done the first time he came, which showed that he had a pancytopenia with white cell count of 1.96. He had an HB of 5.8 and platelets were at 43 with a neutrophil count of 0.82. So from the history and the examinations that we did, the list of problems he had a hepatosplenomegaly with lymphadenopathy and a pancytopenia on the full blood count, which he had a decompensated anemia, but had an asymptomatic thrombocytopenia with a moderate acute malnutrition, which we put a differential diagnosis of lymphoma and a lysosomal storage disorder. So the investigations that we did for our patient, over the series that he stayed in our hospital, he stayed there quite for a long time. So this is just some of the results, the full blood counts that we did. As you can see, the white cell count still were on the lower side. From the time he was admitted, that was in August, all the way up to January. So he had a white cell of 1.96. Once in January, it raised a little bit to 2.53. The hemoglobin went up to 10 because he had received some transfusions whilst he was in the hospital. The platelet count was at 43 from the beginning, then it went up to 72 with a neutrophil count of 0.82, ranging up to 1.25 that was in January. We also did an HB electrophoresis, of which of note is that this HB electrophoresis was done a month after he had received one of his blood transfusions. So he had an hemoglobin S at 34.2% and hemoglobin 0.6%. The clotting profile was also done, which gave him an INR of 1.06. He had a PT of 17 seconds and APTT at 30.2 seconds. On the biochemistry, we did the biochemistry in December and one on the 6th of December and one on the 26th of December, of which his liver enzymes were a little bit elevated. So he had a total bilirubin of 9.2 with LLD of 277. The GGT was at 133 and ALT 130 with an AST of 536. A bone marrow aspirate was also done. So it showed that he had, it was suspicious for a lipid storage disease, giving it a differential of Gaucher's disease. So they had advised that we go ahead and do enzyme assays. On the imaging studies, we did an abdominal ultrasound for him, which showed a massive splenomegaly, massive hepatomegaly. He had a mild ascites with bilateral hydronephrosis. The echo that was done was normal. So on the management, we had started him on nutrition and rehabilitation. So we gave him some nutrient supplements. He was put on ready-to-use nutritional feeds and also HEPS porridge. Supportive management included multiple blood transfusions, as this is a patient who was having a very low HP, and he continued having a pancytopenia. So then finally, we did a splenectomy on the 13th of January this year, of which he was given both the pre and post-op vaccinations. So the intra-op findings, he had a markedly enlarged liver which had rugged surfaces and a huge spleen with fatty tissue. Other organs were okay and intact. So these are just the images of his spleen. On post-operative management, he was given antibiotics and analgesia with adequate hydration, and the wound was being cleaned every day. He had a quick post-op recovery, and he didn't have any noted complications. He received his post-op vaccinations and was placed on long-life PenV with antimalarial prophylaxis. After all this management, the patient was then transferred back to Copperbelt, where he could be near his family after a long stay of 60 days in hospital. The post-operative full blood count, his white cells went up to 8.94. He had a red cell count of 3.46 with an HB of 8.7 and a platelet of 678 with neutrophil count all the way up to 4.35. So for the samples that were gotten for his spleen, the histopathology summary showed that he had a spleen of measuring 30 times 14.5 by 10 centimeters, and it weighed about 2,459 grams. The parenchyma had scanty white pulp with diffuse replacement of red pulp by sheath of enlargement histiocytes with a bland round nucleus and abundant pale eosinophil. So it was suggestive of Gaucher's disease, which involved the spleen. We also managed to do the GBA sequencing analysis. And from the analysis, the comment was he had a severe form of Gaucher's disease type 1. So the further care that is needed right now for our patient, he is currently waiting the enzyme replacement therapy. So as we speak, he's with his grandmother at the Copperbelt province, and we haven't yet initiated him on the enzyme replacement therapy. He is doing well at the moment with no any other complications so far. So that was our presentation. Thank you.
All right. Thank you, Namwaka and team. I know this was a team effort in bringing this presentation together. So maybe at this point we can open it up for some questions from the team, maybe before we go into some discussion surrounding the case.
Just wanted to say thank you very much. That was a very comprehensive presentation and very interesting case. I had a question, although now we do have genetics, but was there anything in the way of neurological involvement, any neurological symptoms at all? Because we know some types of the Gaucher's disease can have neurology involvement. Was there anything in the history to suggest that?
And our patient, he didn't have any neurological symptoms or signs. No, he didn't.
Perfect. And in terms of the bone marrow findings, did you say that there was no trephine? No trephine.
No. There was no. You can go ahead.
Yeah, so there was features in the aspirate, isn't it?
Let's go back.
You go back to the bone marrow, yes. Okay, so from the aspirate, it was suggested that it could be a lysosomal storage disorder, and hence a suggestion of Gaucher's. Okay.
Yes.
Perfect. Very interesting. And my last question, sorry, before other people. So I wondered if how much blood support he needed, whether it's red cells or platelet support. Was he dependent on transfusions for some time? I can see starting HB was around 6.
So from our facility, he received about 3 aliquots of red cells concentrate and about 6 of platelets because we're trying to optimize him for theater. We were given a minimum platelet count of 50 by 10 from the anesthetist. So we're trying to give him that. From the referral facility, he only received blood on 2 occasions. Yeah.
Fantastic. I think we have some hands.
I have a question. I
Somewhere.
don't know how to lift my hand on my device.
Okay. Do you want to go? Maybe perhaps Somway can go first and then Patricia.
Yes, thank you. Thank you very much. Very exciting presentation. My question was, I don't know if at the beginning you gave us the ethnic group of this patient. Is he an indigenous Black Zambian? I'm not sure about that. And then from the literature, is this a first reported case of Gaucher's in this country, or there have been previous reports? Thank you.
Oh, yes, he is. He is an indigenous Zambian. Yes, he's Black. And we've in our facility right now, we've had about 3 cases. I think he is the 3rd case.
Thank you. Thank you.
Welcome.
Patricia, you had a question?
Yes, I did. Wonderful presentation. Thank you. I have 2 questions. How soon after the splenectomy did we have a thrombocytosis? And were we worried about the post-splenectomy thrombocytosis? Did we do serial of those before we sent him home? Because I know his first platelet count was 472, the latest, and then after the splenectomy, it went to 8. Is it 600 or 800? I think I can't remember the value. Then my second question, did we repeat the HB electrophoresis after discharge, knowing that we did it and his was just make sure. Thank you.
So we didn't get to repeat the HB electrophoresis because he was still within the 3-month window from the last time we transfused him on our ward. So he's yet to do it from the facility where we sent him to in the Copper Belt. As for the serial full blood count, so he was scheduled to do another full blood count from the referral facility, but unfortunately we haven't yet gotten word from them if at all they've done it and what the current platelet count is. But from our facility post-op, we did about 2 and they're all below 700,710, yes.
Are there any other questions? Oh, Dr. Wright.
Hi. It was just a question about costs, and how much it now costs. I obviously I'm an adult doctor. I don't treat Gauchers, and I know this used to be an extraordinarily expensive treatment, but that was some years ago. I just wonder what the costs were now, and whether this was going to be manageable by the family.
So this wasn't manageable by the family. For the basic tests like BMA, liver function test, clotting profile, we were able to do using our national insurance scheme, of which a well-wisher had placed him on their scheme, which was helpful. For the enzyme assay and the gene analysis, it was done with collaboration via Dr. Chira and a team in the US, so the ones who helped us with that. So an ordinary family cannot really afford further testing. The most they can do is pretty much the BMA and the few clotting profiles and everything. But yeah, so it's still expensive, and hence we haven't even started him on the enzyme replacement therapy because of funds and lack of access to therapy.
Okay. And the next question, I suppose, was any of the family that need screening at all?
So we haven't screened the rest of the family. Yes, the screened and nobody has presented with anything similar to what he has, but it'd be good to also test the rest of the family.
Thank you, and well done.
Okay.
Yeah, maybe I can come in and add. Thanks, Josh. So, as Leila has indicated, the costs, I think beyond what the insurance team can do, is almost nothing. I think the basically the collaboration or the well wishers that are in the US are the ones that are able to help with the genetic tests. But of course, we also know there's a molecular component that is needed. So giving a holistic sort of management for patients, especially now that we are seeing more, I think is all the more necessary. And the patient who actually even received some enzyme therapy. Her name is Destiny. I think Felix is Dr. Sakala was on the call. Actually has quite a bit more details even about her, and even concerning the enzyme replacement therapy, that was also something that would come as a donation specifically for her by the foundation that Dr. Chua had a collaboration with. Felix, are you able to speak to a bit more of that? Are you in a position to speak? Dr. Sakala,
Hello.
go ahead, Felix.
Thank you so much, Dr. Siame. So for Destiny Kamonga, what we did was to, apart from the bone marrow aspirate findings, we went on to do the enzyme replacement therapy as well as genetic testing. I think it was because of the collaborative effort by a team from Lusaka, USA, as well as Brazil, for how we were able to do biomarkers like chitotriosidase, as well as the genetic testing to confirm the diagnosis. And we started enzyme replacement therapy. But I would say the cost was too huge. I saw some of the bills. So I feel one of the challenges that the team might face in terms of screening the members of the family would be the huge cost
Exactly.
in terms of screening. Yeah.
Precisely. Yeah. Thank you for that addition, Felix. Professor Somo, you have another question? Back to you, Sama, after this.
Yeah, thank you. Yeah, no, I was just wondering, I almost, I was in another meeting and then I saw your WhatsApp message and I joined this. And I'm so happy I didn't decline to follow this. Very, very interesting. My question to the first presenter is, when you look at your list of differentials, you talked about lymphoma, and then suddenly there's lysosomal storage disorder. I was wondering, was this list of differential influenced by the fact that you had 2 previous Gauchers? Because I was wondering if you are somewhere within Zambia in a rural area, even in Lusaka, wouldn't you think of other things first, commoner things as compared to this rare disorder? I was thinking, does this picture fit in a chronic malaria patient? Does it fit in a disseminated tuberculosis? What's your comment on that?
Yes, Dr. Somo, you're right. Of course, we are biased because we have had some similar presentations of the other 2 patients. And our lymphoma came about because this patient also had some lymphadenopathy, which was noted on examination when he presented as well. Yes, but common things are common, you're right.
Fantastic. Any other comments or questions? If you're unable to put your hand up, you could just unmute and go ahead. I think it's very interesting, and thank you so much for presenting. In terms of costs, as Josh was saying, it is very, very expensive, even in the UK. So these patients are usually, we get involved because of for diagnostic purposes, and sometimes they just get referred to us because of the thrombocytopenia, and we manage them jointly with the metabolic medicine team. The testing is very expensive, the treatment is very expensive, but I think additionally there are some clinical trials that are available here in the UK for treatment. So very well done for the Zambia team for managing all these things. And what I can do is I can link in with our metabolic colleagues and see if there are any initiatives like Thilo mentioned in the beginning that could be of help for the Zambia team, if there are any collaborations that could happen in the way of treating Gauchers. But I did note that you have a presentation about Gauchers, is that correct? Would you like to give us a quick overview about the condition, assessment, and management?
Okay.
Yes, perfect.
I'll just run through.
Yes, thank you.
I'll just run through very quickly. So Gaucher's disease was first described by a French dermatologist in 1882. At the time, they had thought to say it was a form of a splenic cancer. So it was not until 1965 when the actual true biochemical nature of Gaucher's disease was understood. So it was discovered to say it is usually caused by a mutation in the GBA gene, and there was equal sexual distribution, males and females being affected equally. It is an autosomal recessive inheritance condition. So it is actually a lysosomal storage disorder, and it is characterized by deposition of glucocerebroside in the cells of the macrophage monocyte system. And this happens due to a deficiency in the enzyme called glucocerebrosidase, and it's more prevalent in the Ashkenazi Jews. So the prevalence, according to the Gaucher's Disease Institute, there's a worldwide prevalence of 0.7 to 1.7 per 100,000 individuals, and the birth incidence amongst the Ashkenazi Jews is 1 in every 850, and that is specifically for type 1. So there are 4 common mutations that are associated with the Ashkenazi Jews. So we have the N370S, the L44P, and the 84INSG, including the IVS2 in up to 95% of the population. So the local and regional data is very scanty. So the pathophysiology, as I alluded to earlier, we know that the macrophage monocyte system is the one that is involved in our immune system, of course, even including the disposing of the old cells. So once they engulf, for example, the old cells, they break them down. So in the cell membranes of these cells, you find that there's the glycophospholipids. So it's these glycophospholipids which are supposed to be digested by the glucocerebrosidase enzyme. So now, because we have a deficiency in that enzyme, the glucocerebroside tends to accumulate in these structures of reticuloendothelial system, involving the liver, the spleen, the bones even, including the brain. Okay, so this is just the pictures illustrating what really happens in the pathophysiology. So based on that, it is therefore classified into 3 types. We have type 1, which is neuropathic, which is the commonest form, followed by type 2, which is an acute neuropathic form, accounting for about less than 5%, and type 3, which is a chronic neuropathic form, accounting for about 5%. Okay, the other subdivisions include the perinatal lethal form and also the one that affects the cardiovascular system. So for the clinical manifestations, for Gaucher's type 1, these are patients who usually present with a thrombocytopenia, chronic fatigue due to anemia, and a hepatosplenomegaly. So the affected individuals who experience infection to various bones of the body, and this results mostly into a bone crisis, a vesicular necrosis, including deformities of bones. And also in rare cases, you find that the affected individuals may experience involvement of the lungs and the kidneys as well. For type 2, it usually occurs in the newborns and the infants, and this one is characterized by neurological complications. The splenomegaly may also occur, and it may be the first symptom, and usually becomes apparent after 6 months of age. Then there's a loss of previously acquired motor skills, including hypotonia, spasticity. They may also present with stiff movements of the arms and the legs, including strabismus. Dysphagia and retroflexion, sometimes failure to thrive and a stridor may occur due to laryngeal spasms. Anemia and thrombocytopenia also occurs. There are skin abnormalities that have been noted as well, and also generalized swelling, and death usually occurs within the first few weeks of life. For type 3, it usually occurs during the first decade of life. It involves the blood and the bone abnormalities as well. Neurological complications may develop and progress slower compared to Gaucher's type 2. There's mental deterioration, ataxia, and myoclonic seizures as well, with a horizontal and a vertical gaze palsy. So they may also present with pulmonary disease, and a wide variability in presentation and clinical course will occur among these patients. So some of them may live up to their teens, all the way up to their early 20s, while others may have even lived much longer than 30 to 40 years of age. So for the diagnosis, a perinatal diagnosis can actually be done if there is a positive or a known GBA gene mutation in the family. So for prenatal diagnosis, amniocentesis and coronary villus sampling may be done, but this one does not determine the type of the disease. Okay, so for confirmatory diagnosis, it's done via enzyme ICs and also genetic analysis to ascertain the mutations that have occurred. So if you have the beta glucosides leukocyte assay is low, then a genetic testing is recommended. And also if two causal genetic defects in conjunction with the enzyme test results, it confirms the diagnosis of Gaucher's disease. So for the individuals who only have one gene defect, excuse me, they may be a carrier. And in the presence of a low enzyme, they may be affected by a second genetic mutation. So referral should be actually advocated for so that appropriate genetic specialists may be done. So for DNA analysis, it will identify individuals who have who carry a mutation in the GBA gene and who can also pass the mutation to their children. So supportive investigations include a full blood count, of course, a reticulocyte count, a BMA, as we saw in our patient, X-rays to demonstrate musculoskeletal deformities, including an echo and a CT scan. Excuse me. Liver enzymes in biochemistry also are recommended for our patients. So for the standard therapies, we have three main goals, and this is to improve the quality of life by allowing them to perform their normal daily activities. We want to prevent severe complications, and also we want this child to normalize their growth and also to reach a normal height and achieving a normal onset of puberty. So currently, the current FDA-approved drug therapy options include the enzyme replacement therapies and also the substrate reduction therapy. Okay, so for the enzyme replacement therapy has been proven effective for individuals with Gaucher's type 1, of which anemia and thrombocytopenia have been noted to have improved, including the enlargement of the liver and the spleen. So for those with systemic manifestations also improve in individuals with type 2 and type 3 who have received enzyme replacement therapies. So however, the enzyme replacement therapy has not been effective in reversing certain neurological symptoms which are found in type 2 and in type 3. So the enzyme replacement therapy is given every 2 weeks via infusion, and the current approved enzyme replacement therapy drugs include the seroenzyme, the velaglucerase alpha, and also the teleglucerase enzymes. So, okay, this is the same thing. For the synthetic form of this drug, we've got, it was approved in 1994, and it's produced by seroenzyme. So this one, it will replace the human lysosomal enzyme, and that is lacking in the individuals with Gaucher's disease. For the substrate replacement therapy, so these ones, they work by actually blocking the production of the glucocerebroside and by also inhibiting the enzyme glucoceramide synthase. So it's not supposed to be used in children, in teenagers, and also in pregnant women, and also the breastfeeding mothers. So genetic counseling is one element that should not be overlooked. So it is recommended for affected individuals and also their families, and also the individuals with Gaucher's are at increased risk of multiple myeloma. So they should be followed up as adults as well. Another modality of treatment is the hematopoietic stem cell transplant. So this one offers a form of treatment that is potentially permanent, but it's usually discouraged because of most of the rejections and the side effects that it comes with. So the prognosis, so some individuals with type 1 have few manifestations and may actually lead a normal life. And for type 2, it is universally poor, and they also, depending on the age of presentation and the aggressiveness of the management. And the life expectancy will vary from several months to several years. For type 3, it also depends on the severity of the disease and the age of onset of therapy. Most of these patients, aggressive myoclonus epilepsy associated with Gaucher's type 3 usually do not fare well. For patients who present with hepatomegaly, they will undergo surgical management like we did for our patient. So splenectomy, which can be done, can either be partial or total. This depends on the extent of the enlargement of the spleen, okay? So it is now only performed in cases of which there is severe splenomegaly and it is not subsiding despite continued enzyme replacement therapy. So the preparations that you do for a patient that you want to undergo a splenectomy involves counseling, also the laboratory workup, as we saw for our patient as well. We need to give these patients pre and post-op vaccination, and also it's a multidisciplinary team involving the pediatric surgeons and the anesthetist as well. So some of the indications for the total splenectomy. So splenectomy will be recommended on a patient who has a massive spleen with mass effect on the abdomen, patients who are presenting with constant pancytopenia and requiring all the time blood transfusions, and those who are presenting with a reduced quality of life, and those that are having no improvement in cytopenia and splenic size despite being on the enzyme replacement therapy for more than 10 months. I think that was all for the literature review of Gaucher's. Thank you.
Fantastic. So I think it's an excellent case and very interesting and really well done for all the efforts that have been completed already. But can I just clarify? So you mentioned that this patient is going to have some enzyme replacement therapy. Where was that going to be from? Did you say from the USA, some kind of collaboration? Is that correct?
Well, we are still in the search for those enzymes.
Okay.
Nobody has yet committed to say they're going to give, but yes, we are still looking for those enzymes.
Okay, perfect. So yes, as I mentioned earlier, I'm going to ask if there's any kind of support that can be provided from this part of the world. Okay, Buseko, you got your hand up?
Yes, thank you very much. Lovely presentation, hematology team, and very elaborate. My question is concerning the preoperative preparation, and in this case, our patient. I can't remember how many units of platelets they received, but just wondering if there were any reactions looking at the amount of platelets that they received. That's my question. Thank you.
Okay, so on all the platelet transfusions that we gave him, we did not any transfusion reactions. No, he didn't have any.
So maybe just to add, Buseko, to what Namaka said, I think the team tried to work as closely as possible with blood bank to ensure that the products that he was receiving were apheresed. And I think this was with the foreknowledge or the foresight of the fact that he would need quite a bit of support, because even initially the nutritional status hindered some of his initial planned surgeries. So the team worked very closely with blood bank as quite early on, just to ensure that some of those reactions that we usually see are averse.
Fantastic. Thank you very, very much.